So if you're paying attention, you'll see that I am actually going to be talking a lot about endocrine testing, but I will talk a little bit about treatment at the end. The reason for that is that I get very excited about endocrine testing, and I just want to make a shout out to Valerie and Joanna, who are endocrinology nurse specialists at Green Lane, who fostered in me this interest in endocrine testing. So that is a endocrinologist or endocrine nurse specialist getting very excited about doing endocrine testing correctly. So it's not just that that we have crazy personalities that we get excited about endocrine testing. If you have a chronic condition, having to have regular blood tests is actually an addition to the burden of your disease. So if we can do the testing correctly the first time, then that means that people will not have to have as much repeat testing. And other than doing blood tests, another way that hormones is tested is 24-hour urine collections, which can be, as you can imagine, quite a burden as well. The reason why endocrine testing can sometimes be a bit different to your usual testing is because hormones are always in context of what else is happening in the body. So, for example, insulin is the hormone most important for glucose homeostasis, and as a person without diabetes, your insulin, your plasma insulin will vary greatly depending on where you are, whether you're fasting, whether you've had a high carb meal or a low carb meal. The purpose of endocrine testing in this setting is for the diagnosis or exclusion of functional neuroendocrine tumours. And often when we're thinking of functional neuroendocrine tumours, we're thinking of carcinoid syndrome, gastrinomas, insulinomas, VIPomas, pheochromocytomas, and paragangliomas. But sort of strictly speaking, pituitary adenomas are also neuroendocrine tumours, parathyroid adenomas, thymoma, medullary carcinoma, and adrenal cortical adenomas and carcinomas. The first test I'm going to talk about is the 24-hour urine 5-HIAA. This is a test for diagnosing carcinoid syndrome, which is a syndrome that develops from amines being secreted by a neuroendocrine tumour. It's got a good specificity, so 100% specificity and a sensitivity of 35 to 73%. If you're getting some of the symptoms of carcinoid syndrome, trying to remember which way around specificity and sensitivity is, this is just a reminder. So specificity means that if you do not have the condition, you will have a negative test. So you'll be correctly identified as a person who does not have the condition. For sensitivity, the sensitivity of this test is a bit low. So that means that there are some people who do have this condition who will have a negative test. So if you get a negative test on your patient, but their symptoms sound very suspicious for carcinoid syndrome, then you should repeat the test. So that makes it a good diagnostic test, but a poor screening test because you are going to miss a lot of people who have the condition. This won't be news for all of you, but when you collect a 24-hour urine sample, you want to completely empty your bladder at the beginning of the test. And then usually it's easiest to do that in the morning. Completely empty your bladder and then start collecting all the urine up until your first pee the next morning. And that's your 24-hour period. You also need to tell people not to eat these foods. The reason for that is that these foods are high in serotonin, and that will interfere with the test for the reasons that I will explain. So, does the diet have a true effect on this test? Well, there's not a lot of evidence for a normal diet, so people haven't studied, like if you just eat your normal food, will this interfere with the test? But when they do laboratory studies and they get people to eat a whole lot of that food, like 3 bananas a day, plus plums, plus a whole lot of pineapple juice, then they get very high levels of 5-HIAA in their urine. So as far as we know, even just eating small amounts of those foods could interfere with the test. So if you remember, I said at the beginning, a negative test, if the test is negative, a person who does not have the condition will have a negative test. But if they eat those foods, then they'll have a positive test. So it's very important to tell people to avoid those foods before the test. What are we actually testing for in this urine test? We are testing for the breakdown product of serotonin. So you can get serotonin in your diet. So that dietary serotonin is identical to the serotonin that you would make in your body. So a test cannot distinguish between dietary serotonin and the serotonin that you make in your body. It's identical. So to correctly do this test, you want to avoid serotonin-containing foods for 3 days prior to the test. And while I didn't talk about it, it's always just a good idea when you're doing this test just to include the patient's medications so that the lab can make sure that that medication will not interfere with their test. Now I'm going to talk about plasma metanephrines. This is a test for pheochromocytoma and paraganglioma. This is a syndrome of where you're producing extra adrenaline and noradrenaline. It's a pretty good test. So if you have the condition, it will pick up in this test most of the time. On the other hand, there is a small group of people who do not have the condition who will also have a positive test. However, if you don't do a resting test, even more people will have a positive test. Why is that? Well, the upright position is a potent stimulator of the autonomic nervous system. So after you've all been sitting here for a while, when you get up and go and have your lunch, your adrenaline will kick in to keep your blood pressure up when you stand, so that you don't all collapse at the end of the session. We don't want this in this test because we are trying to test whether or not someone has abnormal adrenaline production. So to do this test correctly, you need to lie the person down, supine, you insert an intravenous catheter, and then you leave the person alone in a quiet room for 30 minutes. And if you're an expert like Valerie and Joanna, the person will almost fall asleep. And then you come and draw the blood sample out of the IV catheter, because another source of adrenaline is a needle coming towards you for a lot of people, most people. And so this way they don't have that stimulus either. I'm just going to make a mention, often we wouldn't think about a prolactinoma as a neuroendocrine condition, but it actually is. So prolactin, you may recognize from the name, has to do with lactation, but both men and women who are not lactating also produce prolactin, and it's also a stress hormone. So for a lot of people, when they go and get a blood test, they feel a bit stressed because a lot of people don't like needles, and their prolactin will rise. So if you want to get if you want to use this test to really rule out a prolactinoma, then you need to follow the same protocol as you would for plasma metanephrines. The last thing I'm going to talk about with endocrine testing is just that for a lot of hormones, you need to have their target tested at the same time, because as I mentioned in the beginning, using the example of insulin, you have a wide range of what could be normal, depending on what that hormone controls. So for example, parathyroid hormone is the hormone that keeps our calcium balance right. Calcium balance is very important for the normal function of our heart muscle and all our other muscles and our nerves. So our body is very careful to keep our calcium at the right level. So a parathyroid hormone, could be appropriately high, for example, if you're vitamin D deficient. So it's important to measure calcium along with parathyroid hormone. Insulin, of course, you need to measure glucose at the same time. I know that seems obvious, but very often I get phone calls and they're like, oh, this person's insulin is this. Like, what was their glucose? Ah, we didn't measure the glucose. Can you do it again? Ah, they forgot to do the glucose again. So this is a very common reason why people need to have repeat testing, is if they don't have the target, glucose, calcium, whatever tested. For prolactin, so prolactin's main role during lactation is actually to stop a woman from ovulating. It does have roles in the actual lactation, but its very important role is to stop a woman ovulating while she's breastfeeding, because she doesn't really need another baby right now while she's breastfeeding. So if you are abnormally producing prolactin, you've got a prolactinoma, if you're a woman, your ovaries will be suppressed, and if you're a man, your testes will be suppressed. So if you're going to measure someone's prolactin, or if you've measured someone's prolactin and it's high, you will also want to measure their estradiol or testosterone. If you're thinking that someone is producing extra growth hormone, you need to test their IGF-1, and if you think someone's producing too much ACTH, you need to test their cortisol, is the end product, or the cortisol itself is a hormone, but ACTH stimulates cortisol. So a high ACTH may actually be in response to a low cortisol. So I am now going to talk a bit about endocrine treatment, just to keep the organisers happy. The purpose of endocrine treatment in neuroendocrine tumours is the management of symptoms until definitive treatment, or the management if definitive treatment is not possible. So management of symptoms mostly if definitive treatment is not possible. So endocrine treatments are not curative treatments. I'm going to talk about somatostatin analogues, and I'm going to talk about the treatment for hypoglycaemia. You've heard a lot about somatostatin analogues this morning. For the purposes of neuroendocrine tumours, that's octreotide and lanreotide. And they're used for the treatment of carcinoid syndrome, but also used for the treatment of acromegaly, that's excess growth hormone, and also in insulinomas as well. Somatostatin analogues are analogues of the natural occurring hormone somatostatin that binds to the somatostatin receptor, and in the case of octreotide and lanreotide, predominantly to somatostatin receptor 2. That inhibits the release of hormones. And for those of you who are super nerds, somatostatin receptor is a G-coupled protein receptor that connected to cyclic AMP, and it prevents the depolarization of the membrane, which stops the insertion of the vesicles that contain the hormones, preventing the release of hormones. There is some effect on cell cycle arrest, and some apoptosis can occur, which is why there has been the observation that there can be growth arrest of the tumour, but that's not really its main effect. Its main effect is inhibiting the release of hormones. I am just going to make a brief mention of other treatments for carcinoid syndrome. Not everybody gets symptom relief from octreotide, and there are some other options, and one of those is a commonly known drug, ondansetron, which is a serotonin receptor 2 antagonist. I think in the oncology lecture there was a mention that the octreotide study had 42 participants, or 42 and 43 participants in each group. Of the studies of ondansetron in carcinoid syndrome, there have been 6 participants in each group, so even less evidence. But it's a very commonly available drug. Of those 6 participants who received ondansetron, they all had symptomatic relief. So maybe this is something that that should be investigated a bit more. There is a new drug on its way, telotristat. So watch this space in 20 years' time in New Zealand. And lastly, I'm just going to talk about the management of hypoglycemia and insulinoma. And this is because it can be very difficult in some cases to get on top of this. So for all of us now, having had our morning tea, our insulin would have gone up to take in all of that sugar from the muffins. And now you're not eating, so your insulin is starting to go down. That's your first response to a falling blood glucose. If your blood glucose continues to drop further, you will release glucagon from your pancreas, and that will stimulate the liver to break down glycogen to glucose and release that out into the blood. If your glucose starts to fall further, then your adrenaline will kick in. You might start to feel a bit anxious, and glycogen will further be broken down to glucose, and you'll get some new glucose production in the liver as well. If your glucose starts to fall further, growth hormone starts getting stimulated, and then you become more resistant to insulin. If your glucose falls further, then your cortisol will come in as a stress response, make you more insulin resistant, and drive the production of more glucose. If you have, for example, an insulinoma, or if you've taken too much of your exogenous insulin, if you have diabetes, and your normal mechanisms cannot overcome the amount of insulin you have hanging around, then you will start to get confused, and then at end stage you will potentially have seizures and collapse. So for those who have an insulinoma, they will often themselves start having more frequent meals, because they will notice that when they go without meals for any length of time, they start to feel they start getting the adrenaline going, but there's no harm in recommending that people do that as well. There is a medication called diazoxide, which reduces the release of insulin from the insulinoma. You can use somatostatin analogues, so that's octreotide, but you have to keep a close eye on the person, because it can sometimes be counterproductive, because although its role is to reduce insulin, it also reduces glucagon release as well. So you just have to be a bit careful when you start a somatostatin analogue when you're treating insulinomas. And then you can, if you're still having trouble getting on top of it, you can start treating people with glucocorticoids. So you'll be familiar with these medications. That includes hydrocortisone, but more often you'll use prednisone or dexamethasone. Actually, just because it was mentioned earlier, everolimus is also being used in some places where it's readily available for the treatment of insulinoma as well. That's because one of the side effects is insulin resistance, and a lot of people who have everolimus for other conditions end up getting diabetes. So it's sort of using its side effect against it. So in summary, when you're when you're doing hormone testing, consider the context. And although sometimes the instructions for endocrine testing can be complicated, it does improve the quality of the test. So it does make a difference in terms of people having to have repeat testing or getting the correct diagnosis.